hope all of you are seeing the screen well. Can somebody please tell me whether you're seeing it all right?
Yes,
Yes,
sir.
we are.
Arjuna?
Yeah, yeah,
Okay, right,
yeah.
fine. Thank you. Right, facilitating a good death, a physician perspective. The first thing is like, we know that death is very difficult. It is difficult for the patient, it's difficult for the family and the carers, and it's difficult for us as well. It's difficult for patients and families. There is separation from loved ones. I think that is probably the one which makes all of us be worried about death of ourselves or death of our loved ones, because the process of separation, it worries us, it makes us very anxious. Then of course, for somebody who is dying, maybe within quotes prematurely, um, lots of future hopes. If we were planning to live for much longer, and if we had made plans for the future, and if we feel that we have many things left to do, many things left to achieve, many goodbyes to say, many people to love, etc., the loss of future hopes makes death difficult for patients. Uh, and then, of course, even the families find this loss of future hopes because, for instance, if a father dies when the children are young, the children and the mother would all worry about the future. What they could achieve with the father being there may not be achievable now. Then, of course, there are the uncertainties about afterlife. Different people from different religions have different beliefs about afterlife, and we all seek solace and comfort in religions to deal with afterlife. Unfortunately, some afterlives are not that comfortable, because somebody might believe that after death that they go to God, which is, I suppose, a good place to be. But some others who believe differently might worry about where they would be born after birth. So there is a lot of uncertainty about afterlife. And then, of course, patients worry, I've not put it down here, about the process of dying. Because none of us have died before, so we don't know how bad it will be, whether it will be a very difficult experience. Like, is it going to be more difficult than a PCR being done with a long stick in the nose? Is it more painful than that? Or is it kind of a very comfortable, sort of, falling asleep type of thing? So we don't know what this process of dying is. So that this makes death very difficult for patients and families. Now, it is difficult for doctors as well, because our training is not to deal with death. Our entire medical curriculum, both as undergraduates and postgraduates, uh, except for maybe a very odd little bit of like talk like this, generally it's all about curing and controlling diseases. If we can't cure, we at least learn to relieve patients from all the discomforts that they have. So it's all about adding that extra month or extra years to people's lives. I mean, all our medical practice can be summarized in two phrases: reduce morbidity, reduce mortality. That's our entire training program. Now, when we have to deal with uh, patients dying, on the one hand, we feel at times that we take it upon us as a failure, as if we have failed because our success is making patients live. So when patients die, naturally, that has to be our failure. So that makes us very uncomfortable. And even if we do not feel that we have failed, even if we feel that we've done the best possible for the patient, the whole process of dying and caring for the dying is out of our comfort zone. We have had very little training with that. What was actually a century ago, what was actually the work of village elders, where, if somebody was dying, the village elders, we would gather around, relieve the family of some distress, and then be there around to support the family and the dying patient. So that's what happened a century ago. Now, most of the patients die in hospitals. And we doctors who hardly know these patients from a personal perspective have been asked to be the carers during their dying moments. And frankly, what do we know about seeing someone through death? Some of us have not seen any of our close family members die. So we are ill trained for this task, and then we are completely out of our depth here. That's what makes death so difficult. Of course, death is difficult, but is this death bad? Conversely, is death good? There are people who take their own lives. There are people who feel that, I've lived enough. It's time to move on. So is it a good thing? All of us, the closest we've come to death is falling asleep. And, sleep is probably one of the greatest pleasures that we've ever known. It's really nice. We do it every day. So is death a good thing? Or is it bad? Or is it neither? The Epicurus, the Greek philosopher from the 4th century BC, he founded the school of philosophy called Epicureanism. He famously said, when we are, death is not come. When we are there, death has not come. And when death is come, we are not. Well, when death has come, we are not there. So from the dying person, death is bad. Something can be good or bad if we are there to experience that. So when death comes, if we are not there, he feels that it's neither good nor bad. Is that really so? Some feel otherwise. Now, this is an image from the 18th century. This is called Death and the Maiden. Here we see a very young woman who is being visited upon by death. Death is depicted as a skeleton-like figure, ominous dark figure, a young woman. And death has come to take this young and beautiful woman away. And she's upset about going. So the maiden says, pass me by, oh, pass me by. Go, fierce man of bones. I'm still young. Go, rather. And do not touch me, do not touch me. This is a poem by Matthias Claudius, the German poet from round about the same time. Seeing this image, he wrote this poem. And then, of course, death tells the maiden, give me your hand, you beautiful and tender form. I'm a friend, and come not to punish. Be of good cheer, I'm not fierce. Softly shall you sleep in my arms. So death insists that death is not a bad thing, invites the young maiden to softly sleep in his hands. But of course, the maiden is not happy. So this conflict between is death good and bad has been very beautifully written by Claudius in this poem. This was originally in German. This is an English translation. So when is death bad? If death deprives a future life that is valued by the patient and the family, that perhaps would be bad. Now, if the family feels that the person as he or she is, if they live further, that is of great value to the family would see this as a bad death. At times, if the patient feels that there is so much left to do, if I can go on even with this whatever disabilities that have been given to me by this illness, then it is of value to me. Now, this again highlights a very important point, that is the value of life. Now, to understand value of death, we need to understand the value of life. It is the medical community very loosely uses the term, this patient, the quality of life is poor or the quality of life is good, etc. But our presumptions on quality and value of life of patients may not be correct. It is very difficult for us to assume that somebody with a particular disability, his quality of life is poor and therefore his life is not of value. That is, I honestly don't think that that's really part of our work. It is very difficult to understand. Somebody can look at, anybody can look at other people and say, this person doesn't have enough money like me. How can he live without an Apple phone? How can he live with only having a Samsung phone? What is his quality of life? It must be very poor. So it's a very subjective thing. So what death becomes bad if the patient believes that that he's being deprived of a future life that is valued by him. Of course, at times, patients and the families feel that the patient has lived a full, good life, has been unwell, does not, maybe a father or mother would not like to go on suffering like this because, this is not what they wanted from life. So even if they were to die now, there would not be a deprivation of a future life that is valued. So the patient and the family may feel that way as well. So death will be bad if they feel that there is a deprivation, but it would not be bad if everybody is accepting that there is no valuable life left for them. Then, of course, death can be bad if the person dies with wishes around this dying process unfulfilled. For instance, now I might decide that I do not wish to have cardiopulmonary resuscitation if I were to have a heart attack or so. I would say I'll just take the normal medicines, but I don't want to be fixed to machines and things like that. And then, that's my wish, and I tell my family also that wish. But say if I'm working in the hospital and then I have a heart attack, I have a VT collapse or something, then of course other people may not be aware of my wishes, or in the emergency situation, doctors may not be aware of my wishes and thoughts. And then they may intubate me and then fix me onto machines. I may never know that I underwent that before dying, but still my dying wishes have been unfulfilled. I may never know, but still that may amount to a bad death because the person's last wishes were not respected. Now, very often, this really happens often, because at times even our thoughts, though we within our minds think that I don't want to get fixed onto a machine, etc., doctors are not in the habit usually of speaking about life support with patients and families, and then patients are also not in the habit of letting other people know their wishes. So their wishes are within their minds, and then wishes may not be known. So this can happen quite commonly. Something else that we have seen is there are some patients who wish that their eyes be gifted to the Eye Donation Society, the corneas, or that their bodies be gifted to, say, the medical faculty or something to that effect. And then, of course, the relations after death may not feel that they should do that, but they will have their own funeral rites, because after dying, the corpse belongs to the legal ownership is with the family. Then again, the patient will not know, as Epicurus said, because the patient has died, but still we could consider that to be some kind of bad death because the dying process has been unfulfilled. Then, of course, the third aspect, that is, death can be bad if in the process of dying, the patient suffers. suffers distressing physical discomforts such as pain, nausea, and breathlessness. I want you all to think about this. The commonest distressing three symptoms which dying patients experience are pain, nausea, vomiting, and then breathlessness. So if they die having these things uncontrolled, then the process of dying would be maybe bad. If they harbor feelings such as anger, agitation, confusion, hopelessness, if they're confused, they can't recognize who is around them. If their family, they can't recognize, or they're agitated, they're pulling all the tubes, they don't know, they're delirious, or they feel so angry that this is happening to them. If they have such emotional feelings in the dying process, that may amount to a bad death. Bad death. I hope all of you all are with me. Sujanita, are you okay? You are hearing me? All right?
Yes, yes, I can hear you very well. Thank you.
Okay, right. So this brings us to the question, how do we as physicians prevent a bad death for one of our patients? So how do we do that? First thing is to understand that preventing a bad death is not the duty of palliative care specialists. Now, palliative care specialists are important. I think the PGIM programs are set in place. We'll have palliative care specialists. Palliative care specialists may one day head certain palliative care institutions. That is also possible. They will need to train other doctors like you and I, who are acute medicine physicians and cardiologists and endocrinologists and so on and so forth in palliative care. But what you must understand is most of the patients receive their terminal care in general medical wards or in the community. Now, end of life care may be in the hospital or in the community, but most of the time their last few months are spent in the community. It is very rare to find somebody who has been in hospital for 2 months before they die. Very often they're in the community at home. So palliative care has to be the forte of all of us. It's a work of everyone, and all of us have to be strong in our palliative care, our end of life care, and care of the dying. They're slightly different. Palliative care might be about the last 1 year of somebody's life. If you see someone and if you feel that they are not likely to live for 1 year, then it's time to think seriously about palliative care. End of life care would be the last few days or weeks of somebody's life. And then, of course, the care of the dying might be the last 24 to 48 hours of somebody's death. So we need to be competent to manage all three stages, just like we are able to manage other things as well. So we need to learn about palliative care, end of life care, care of the dying. I'll talk a little bit about today, but other things we need to cover, and maybe that's the subject area for another talk for you all. Then, of course, so it's not, we have to learn, get our selves trained in these things. We have to know. And then, of course, then we provide optimum end-of-life care to ensure comfort and dignity of the dying person and the family. So dignity is a bit of a big word. It's quite vague. A lot of people talk about a dignified death. Nobody really knows what a dignified death in a particular cultural context. It might be known how it is in the West, but very little work has been done in Sri Lanka in terms of what is a dignified death. But shall we say a comfortable and not a chaotic death? So we have to do our level best to do that. And the whole process is based on empathy and profound communication. Now, I've used the word profound because, for the lack of a better word, I wanted to say it should be even better than good communication. It has to be very, very good communication, and it has to be based on empathy. So that brings us to the question what empathy is. Now, you may have, I've heard many people speak about empathy as, how do they say it? Getting into the boots of the affected person. So here the affected persons will be the family and the patient. So I always had problems because we don't wear boots, and it's a very alien expression. It's probably not a very apt expression. So what empathy really means is our ability to understand the thoughts and the feelings. Patients have thoughts and they have feelings. Families have thoughts, families have feelings. The thoughts and the feelings of the family and the patient. So empathetic communication means we will speak with them and we will deal with them, communicate with them, whilst paying great attention to their thoughts and feelings. And this has to be a ongoing process. It's not just one communication which says, okay, your relative will die soon, or as they are dying, you call them and say, he's dying, or when they die, you call them and say he's dead. It's not quite that, but it's an ongoing process, ongoing exploration of the changing needs of the patient and the family. So that's the basis of providing or preventing a bad death. Empathetic and regular, ongoing, profound communication. So, to understand what a bad death is, I have a case study. So, this is the case study, The Bad Death of Franz Schubert. I'm sure many of you may know Schubert. Schubert was an Austrian music composer from the Romantic period. Somebody music some particular music a fellow composer once commented that Schubert's music was closest to God. He was a prolific music composer. He lived only 31 years. He was born in 1797, died in 1828. He wrote an astounding number of music compositions, uh, what are called songs, leads. He wrote 600 of them, 600 leads, and so much of chamber music. He's not as well known as, say, Beethoven and Mozart, because he did not write that many concert hall music, but he wrote chamber music, people which people could play on their own and enjoy. So he's a prolific, brilliant, one of the greatest composers ever. So you might wonder why I chose Schubert as my model for the bad death case study. That's because for Claudius's poem, which we read earlier, Schubert wrote a music. Schubert transformed that into a song. A song in German is Lied. So he wrote a Lied called Death and the Maiden, and it was so powerful and so popular that actually he incorporated this short piece of music subsequently, about 7 years later, a little before his death. He wrote the 14th string quartet, and in the second movement, he incorporated this Death and the Maiden theme, and this remains today one of the greatest pieces of music ever written. The string quartet, the 14th string quartet, by named The Death and the Maiden. If you all have some interest in music, and if you all have the time, please go and listen to that at some stage. It's a wonderful piece of music. Now, Schubert contracted syphilis during his, he lived anyway only 31 years. In his 20s, he contracted syphilis, and that caused deteriorating health, and he kept away from society. Whenever the secondary syphilis rash came, he found it very embarrassing. And when he performed and when people saw the rash, they used to comment on the rash in whispered tones, and that was very embarrassing to Schubert. So he led an unhappy life prior to death, deteriorating health. Of course, he didn't die from syphilis. He died from an illness which was diagnosed at that time as typhus abdominalis, which we think now was typhoid. Now, I don't know whether you know why typhoid is called typhoid. The medical community had found an illness called typhus long time ago, by about the 18th century, and then subsequently they came up on this other illness which looked a lot like typhus, but which had actually other manifestations. So because it looked so much like typhus, they named it typhoid. Typhus is the first one which came along, but typhoid is the second. Typhus was built on that. So Schubert's death was from typhoid. So we'll look at what happened to Schubert. Now, there was a composer called Lashner, who was a fellow composer and Schubert's friend. From Schubert's life's last bits, there are these quotations. We'll look at some of these things. When I came into his room, he was lying with his face turned to the wall in the deepest feverish delirium. Added to this was scanty nursing and a badly heated room, on the walls of which the damp was running down. So that is the environment in which Schubert was being nursed during his last few days. Scanty nursing, badly heated room, damp walls, that's where he was. So when the patient is dying, we need to be mindful of the environment. Should not be the darkest corner close to the toilet, which should be the place where the dying patient is placed and the relations are there. That should not be. It should be a place ideally with appropriate lighting. But though there is appropriate lighting, it is important to prevent delirium, etc., that we try to create a day-night pattern for the patient. That is, draw the curtains and make it dark inside our wards or inside the patient's room at home during the night, but have good bright daylight coming during the day. This day-night pattern should be maintained. Cleanliness around the patient. He should not be dying in his own excreta. He should be kept very clean, free of disturbing noises. This may not be possible in our busy general medical wards, but as much as possible, he should be given that freedom from noise, and good nursing care. Good nursing care where he is looked after by the nurses or at home, that we provide the nursing care. Now, I've included a picture here. You might think that I've taken these off from some hotel or maybe some ICC, COVID ICC. This is not. This is actually a bed in which a very dear friend of mine died some time ago. This is from the palliative care center attached to Teaching Hospital Karapitiya. We have a specialist palliative care center. It's a wonderful place. If you all have time, I think you should visit this place. This is where patients come at times to spend their last days. We may never be able to achieve this kind of care in the ordinary wards, but this would be the ideal, just for you all to show that this is actually a bed where people die. If we try, we can create better environments. Back to Schubert. He says, I'm ill. I've eaten nothing for 11 days, and I have drunk nothing. I totter feebly and shakily from my chair to bed and back again. Rina is treating me. If I ever take anything, I bring it up at once. Rina was the king's physician who was attending to Schubert as well. If I ever take anything, I bring it up at once. Nausea and vomiting. So the second way that we can prevent a bad death is alleviate distressing symptoms. I told you about pain, nausea, and breathlessness. Nausea, vomiting. Pain, it is important not to over-sedate in order to retain the patient's ability to communicate as well as address any underlying causes for pain. Now, it is easy for us to give a higher dose of morphine. Patient is sleeping, patient is deeply sedated, there will be no pain and the patient will die that way. But of course, if we do that, we will rob the patient of the last few hours where he could actually communicate and actually take leave of the family. And the family may actually be able to hold his hand. He might be able to touch somebody and say all that he has to say. So yes, pain has to be relieved, but make sure that we do not overdo that so that the patient becomes deeply drowsy with the morphine. I mean, if somebody can drink paracetamol syrup, obviously, when people are close to that, they may not be able to drink and retain. If they can, at least tablets. If you can't give tablets, paracetamol syrup might be an option. If the patient can't take orally, yes, parenteral pain relief preparation, the one that we have is morphine. We can give morphine solution. I don't know whether that's available here, but we could certainly give morphine subcutaneously or through a butterfly cannula, some kind of morphine infusion we can give. We can, but it is important to relieve pain, but not to make the patient completely, totally drowsy. It's a fine balance. Then, of course, nausea and vomiting, we can give intravenous or some kind of antiemetics. And then, of course, if the patient has some underlying cause for the vomiting, we can address that as well. All these things, if there is an underlying cause, we can address that as well. Uh, so everywhere we have to understand why we do symptom relief. If we can address the underlying cause and take away that cause, then of course the symptoms will go. Then breathlessness, again, oxygen only for symptomatic hypoxemia. So many patients who are short of breath do not need oxygen because oxygen is not going to make a difference in them. Opioids may be used to relieve that breathlessness if the patient is having, that may be useful. Benzodiazepines may be useful. Then, of course, address underlying cause. Uh, So that is why, though we don't usually give antibiotics during the terminal stages, if we feel that there is an underlying massive chest infection which is causing the breathlessness, and if we do not give antibiotics, and the breathlessness will become worsen, or if we do not nebulize the breathlessness, then of course there's no harm in doing whatever that is necessary to reduce breathlessness. So only that is which is necessary, but there is no regular prescription to do that. So these are the three symptoms. Then of course, some people have noisy respiratory secretions that may not be all that bothersome to the patient, but the family find it very unsettling. Their respiratory rattles, or that's called the death rattle. Hyoscine IV we do not have, but when you all go overseas to train, you will find hyoscine. To my knowledge, there is not hyoscine IV. I don't know, correct me if I'm wrong. Atropine might help, of course, knowing that atropine can cause palpitations and all that, but atropine, small doses, could take away some of these uncomfortable breath sounds that the family will find very difficult to bear. So alleviate distressing symptoms. So we are creating a good environment, we are alleviating distressing symptoms. What must we do to avoid? That's a very strange question. What must we do to avoid a bad death? So these are again very important. Non-essential drugs must be stopped. Now there may not be any use in continuing with the aspirin or the clopidogrel or the atorvastatin when the patient is likely to die within the next few hours. As taking oral drugs becomes difficult, then continued, like opioid antiemetics, anxiolytics can be converted to subcutaneous rule, and then syringe drivers can be used. Butterfly cannulas are very useful things to give morphine infusions. Anticipatory prescribing as opposed to PRN prescribing. We don't have to wait till the patient becomes, starts vomiting all over the place. But if we feel that the patient has nausea, likely to vomit, so we'll anticipate and give an antiemetic rather than waiting the patient to start vomiting. We will anticipate pain and treat rather than waiting for the patient to start howling in pain prior to death. That's called anticipatory prescribing. Inappropriate interventions such as blood tests and monitoring vital signs should be discontinued. I mean, how many times do we see a dying patient continue connected onto the multipara monitor? Now, everybody's monitor is there. So, and when then the relations also get very upset when they see all sorts of different heart patterns. They also learn this after some time, how to look at that, and then that becomes important. So do not monitor. There is no point in monitoring this patient who is dying. And then, of course, there's no point in arranging any more blood tests. Then, of course, avoid CPR in patients, in these dying patients, because we know that it is futile. CPR or any medical measure should be commenced only if it is likely to make the patient survive this illness. So if it's not likely to make the patient survive the illness, CPR becomes futile. We do not start CPR in these patients. So we need to think beforehand about whether we are going to initiate CPR for any patient or whether we are not going to initiate, and that decision has to be made with the team together. Any, not just the CPR, any intervention, that's the that's the justification. You will give any treatment. You will not give any treatment which you think is not going to make the patient survive this illness. So these are some of the other things that we need to think about. So back to Schubert. I in torture go my way, nearing doom's destructive day. Take my life, my flesh and blood, plunge it all in Leeds flood. This was a few days before, not quite in the dying moments, but what does this tell us? What does this quote tell us? I want you all to think about this. What's he trying to tell us? His doctors. We need to look at anxiety, agitated, and what's called agitated depression in patients. Anxiety and agitation, benzodiazepines will be helpful for anxiety and agitation. Then, of course, relief of physical symptoms. For depression, if you feel that the patient is depressed in the days prior to the end, certain medications may be helped, or a good psychotherapist may be able to help the patient. So that you might have to think, diagnose, detect, and arrange for appropriate management. So we've looked at three things: the environment, relief of the distressing physical symptoms, some important decisions that you need to take about not doing certain things, then of course looking actively for anxiety, agitation, agitated depression. Now mind you, here the patient is not delirious, he's quite compos mentis. I mean, his mental state is quite all right. And then of course he is anxious and agitated about impending death. Back to Schubert again. On the evening before his death, though only half conscious, he said to me, I implore you to transfer me to my room, not to leave me here in this corner under the earth. Do I then deserve no place above the earth? I answered him. So the brother says, the Schubert tells this to his brother, and the brother says, Dear Franz, rest assured, believe me, believe your brother Ferdinand, whom you have always trusted and who loves you so much. You are in the room which you have always been in so far and lie in your bed. And Schubert says, no, it is not true. Beethoven does not lie here. What is this? We need to recognize this in our patients. This is delirium. The patient is not oriented in time and place. Schubert believes that he has already been buried and he wants to come out from under the earth. So we need to manage delirium. We might have to use an antipsychotic as well as correct certain underlying metabolic abnormalities. Extremely important to remember that we should not give benzodiazepines to relieve delirium. Benzodiazepines are useful for agitation, but if the patient who is agitated is delirious, benzodiazepines will worsen the delirium. Delirium should not be treated with opioids. That will worsen the confusion. It is an antipsychotic which will be necessary for delirium management. We often use things like olanzapine. The Rapitab olanzapine can be dissolved in water and can be given as a liquid. That might be possible, or maybe something like haloperidol could help us overcome delirium. but not benzodiazepines and opioids. So we've spoken about so far about environment, distressing, relieving distressing symptoms, certain things which we must avoid, such as unnecessary medicine and monitoring, agitation, confusion, then delirium, and then of course spiritual support. Now, when we read about Schubert's death, there is no mention about any spiritual input that he required during the last hours, but this is an extremely important aspect in the culture that we practice in. We need to support the patient and the family's spiritual needs. Now, it's not, I'm not suggesting that everybody's patient gets pirit through earphones in his ear. That is not what I'm suggesting, but inquire into the spiritual needs, if any, of the patient, and then spiritual needs of the family, if any, because the family on their own will be too scared. People are scared of doctors, unfortunately. So they are unlikely to come and ask you whether they could have certain spiritual procedures conducted in the ward. They will be scared. But you could check with them whether they need any help, and then, of course, support, because we are very lucky in our hospital. For the Buddhists, we have the Bhikshu ward, from which some of the monks come and support, not the ill monks, but the other monks who are caring will come and support our patients. Other religions also, there are, not within the hospital, but there is support available. So we need to support both the family and the patient. Even if the patient is unconscious, if the family needs some support, we must do that. This picture is again from our hospital. This is again I have taken from the palliative care center in the Harapitia hospital. Again, a small enclosure in which people of any religion could go and worship, pray, and be with and fulfill their spiritual needs. So this kind of setup is useful for a hospital. Not, it has to be a multi-religious or secular thing where everybody has access to. But think about that and support the patient. Now, all this while we spoke about how to prevent a bad death. So we come to what's called the next aspect, that is, could there be something called a good death? Can anybody have a good death? So how do we facilitate a good death for our patients? Our family members maybe one day, and us maybe one day, because as I told you, this is the one universal experience. I mean, some of us will get COVID, but some others will not get COVID. But all of us will die one day from COVID or something else. So this is an important slide for all of us to reflect upon. One is live fully a life that is valued. The patient must feel that we have lived fully a valuable life and there is no more valuable life left. We come to the age that to die well, you need to live well. So all of us need to make sure that we live fully a valuable life and we live it fully. And then what must be understood is that to ensure that a life is lived fully, we have only a minimal role. As physicians, we have probably no role in that. Then, of course, the end of life wishes, if indicated previously, if they are respected, then that will be a good death. Now, if the patient has to decide, if the patient can decide beforehand whether the patient wishes to die in the hospital or at home, or if the relations know whether the patient would like to die, facilitating that would be a good thing. Patient may not be aware, still it will be a good death because they died where they wanted to die. Whether to have CP or life support, if the patient has made certain decisions beforehand and if they are carried out, that will be a good death. If the patient has any organ donation wishes and if they are carried out, that will be a good death. Now this process is partly in the hands of the family and partly in the hands of the attending physician. What is within us, we can try to do. For example, life support, CPR. If the patient wishes to, die at home, facilitating a discharge and getting the patient to go home before they die, that is one way that we can ensure that it is a good death. Then, of course, I put in italics the a few things that we have definite control over. One is free of, or if we can't free them, minimal distressing symptoms. And I told you the three most important symptoms will be pain, breathlessness, and nausea. In nausea, those will be the symptoms. We need to address those three. Then, of course, if the patient can feel comfort, calm, reassurance, awareness of the presence of loved ones around the dying person, then that might make the death good. So this is where we need to address the other symptoms that we spoke about: the agitation, the depression, the anxiety, delirium, the spiritual needs. That's the next one. Then, of course, it's not just the patient. In a good death, the patient has to have all that. But in addition to that, the family is an integral part in our culture, and the family members also have certain needs to be fulfilled for the relatives' death to be good. They have to have good communication with the healthcare workers. That's why an ongoing, empathetic, profound communication and a profound dialogue is so important and so valuable. And at the end of the day, we have to make sure that some positive memories from the last days of the patient are created in the minds of the family. So our effort should be to facilitate that kind of memories for the patient, so that, if the patient looks good, if the patient is well nursed, patient is in a good lighted corner, patient is not agitated, delirious, all that, then the families will carry some very good positive memories of the last days of the patient's life. It's not only the patient and the family, but it's the doctors and other healthcare workers as well. For a death, for us to feel good, we have to feel that we provided the patient was provided the best possible care. Best means not everything to prolong his life by another 1 hour or something, but the best comfort care that somebody dying can have, that we provided for that patient. And that helps us to feel to, because I started saying by saying that death is uncomfortable for us, but we can feel comfortable with our patients dying, and we feel our patients have had a good death if we can facilitate that. And that, in the long term, will contribute a lot towards reducing burnout as well. So I come to the final slide of my talk with you. We are funambulists. This is a big word. Funambulists are tightrope walkers. So even if you have not learned much medicine, I hope you have learned some music and some English during this talk. So funambulists are tightrope walkers. The tightrope that we are walking when we are caring for dying patients is, are we, by what we are doing, prolonging life, good quality, valuable life, or are we prolonging death, which might amount to a maleficence for the patient? Prolonging good quality, valuable life, valuable from the patient's perspective, is beneficence. Prolonging suffering and unhappy death is maleficence. So we need to make sure by what we do, we are prolonging life, but we are not prolonging death. And that is the question, as Hamlet says, that we need to all keep in mind during the patient's last few days, our family members' last few days, and maybe our own last few days. Thank you very much. I shall be happy to answer any questions if anybody wishes to. If anybody has comments, questions, I'll be happy to